variety of very well-established patient-reported outcome measures. And so if patient-reported outcome measures are our current standard of how we're going to measure functional outcomes, we should dig into patient-reported outcomes a little bit. So patient-reported outcome measures in their modern form go back to about the 1980s and 1990s. And one of the earliest ones was the short form 36 survey, which was developed by the RAND Health Policy Corporation in Santa Monica, California, which still exists and does a lot of good work. And they developed a 36-item survey with questions pulled from other studies that were well validated in other contexts. And the survey assessed different domains of patients' health, so physical function, pain, social functioning, mental health, and assessed patients' health in a variety of domains. And crucially, each question had answer choices that were on a quote-unquote Likert scale. And so this is a very familiar type of scale where you have your level of agreement or disagreement on a symmetric scale. So excellent, very good, good, fair, poor, or much better, somewhat better, about the same, somewhat worse, much worse. And so this is how almost all PROMs answer choices are now. This is one of the first and still used metrics that use that. And so SF36 use has exploded since the 1990s, and with it, patient-reported outcome measure reporting across many fields of orthopedic surgery has also been increasing. And so in total knee arthroplasty here in the middle, also in the shoulder literature here on the right. And in 2024, Shapiro et al. Published in JOS the results of a survey sent out by the AAOS PROMS work group. This was sent to 612 surgeons. A majority of surgeons surveyed said that they feel that PROMs are important, but a majority also said that they are not currently collecting them in their clinical practice. And some of the barriers that they saw were concerns about staff burden, challenges in patients completing the PROMs, whether they didn't have time or whether they couldn't access, let's say, the web interface to do them, that they're too costly to implement, at least in their current form, and also that surgeons are unsure which PROM measures to use. And so if PROMs are one of the standard way that we're going to record functional outcomes, but clearly we're having problems, and a lot of people, in a lot of cases, we're not collecting them. It helps still to go back to a little bit of PROMs 101 and, what are the core elements of PROMs that we need to focus on to make them better. So let's talk about disease versus domain-specific PROMs, a little bit about item response theory and computerized adaptive testing, and also minimum clinically important differences in how you calculate those. So PROMs can broadly be dichotomized into disease-specific and domain-specific. So what does that mean? So a disease-specific PROM is designed to assess the outcome of patients who have a particular condition, and not necessarily patients who have another condition might cause the same pain, but it's a different condition. So the WOMAC, for example, the Western Ontario McMaster University Arthritis Index for patients with osteoarthritis, or the FAM, the Foot and Ankle Ability Measure for foot and ankle conditions. In contrast, domain-specific patient-reported outcome measures look at a specific domain of health, so pain or mental health or your physical function, apart from the disease causing that the disability or the problems with that domain. And so, for example, the brief pain inventory, the hospital anxiety and depression scale, as well as a newer measure that has become widely used, which is PROMIS. And so what's PROMIS? So PROMIS is a group of patient-reported outcome measures that started in the early 2000s and was initially funded by and really pushed forward by the NIH as part of their 2002 roadmap for medical research. And so one of the things that the NIH wanted to do to improve medical research is they wanted to have a generalized all-purpose patient-reported outcome measure. And they wanted such a measure to measure domains of health, so not be disease-specific, be broadly generalizable, mental health, physical health, social health, et cetera. They wanted the PROs to be normalized to the general population, so they all have a mean of 50 and a standard deviation of 10. They wanted reduced respondent burden. So as said in the AOS survey, staff and patient time burden is a huge problem. And so they wanted to use item response theory in CAT. And then they also wanted fewer psychometric or test-taking errors. So they didn't want systematic errors coming from the patient-reported outcome measures. And PROMIS has been, increasing in use in orthopedic surgery dramatically since 2010, with 321 papers, including PROMIS, in the orthopedic surgery literature in 2024. But some of these sort of psychometric terms, item response theory, ceiling floor effects, kind of a word salad. So let's dig into some of that a little bit. So what's item response theory? In item response theory, this is in contrast to classical test theory. And so classical test theory says, I want to survey how a patient's doing, say a patient with hip osteoarthritis. I'm going to get 20, 30, 40 questions together, and we're going to put all those questions together, get a bunch of patients with arthritis, maybe some control patients, and we're going to give them the whole survey. We're going to see how many questions they respond yes, and how many questions they respond no. The whole survey is a unit, and we test and validate the whole survey together. Item response theory is different. Item response theory says each item, meaning question, is its own test. And let's lay out the items and understand where they are on quote unquote latent trait. And so that just means the spectrum of physical function or the spectrum of mental health, depression, anxiety. And let's, for each item, understand its ability to differentiate between people at a given section of the trait scale. So for example, for physical function, you might have an item that says, can you run 10 miles? And obviously that differentiates between people at the very high end of the physical function scale, but not people in the middle or at the bottom end. Or you might have an item that says, can you carry a shopping bag? And that works well to differentiate patients at the bottom of the physical function scale, but maybe not the middle or the top. And so you test each item individually in your testing cohort of patients and controls, and you understand how it works individually. And why would you do that? Well, the advantage of that is that then you can do computerized adaptive testing. What computerized adaptive testing is, it's a very simple concept and almost surprising that not all problems work like this, but it requires a lot of groundwork to make it happen. And so computerized adaptive testing says, okay, I have 160 items that test physical function, but rather than have everybody fill out the whole survey, I'm just going to start in the middle. And then depending on how they respond to the first question, I will choose another question. Depending on how they respond to that, I will target and narrow in on their true physical function. And so, for example, can you do 2 hours of physical labor? No. What about yard work? No. Can you carry a shopping bag? Kind of. Okay, your score is 30. Can you do 2 hours of physical labor? Absolutely. What about strenuous outdoor sports? Yes. Run 2 miles fast? Sure. Okay, your score is 65. So PROMIS physical function works like this. It usually administers 4 questions. It usually takes 2 minutes or less to have a highly reproducible and accurate number for a patient's physical function. And so that's one of the huge benefits of PROMIS and why they used item response theory. Ceiling and floor effects. And so a lot of older patient-reported outcome measures have problems with ceiling and floor effects, which means people with very high or very low levels of the trait, the survey can't distinguish between them. And so, for example, if you have somebody who, again, with physical function says that, you have one person who can easily run 5 miles and one person who can easily run 10 miles, you might not have any questions all the way up at that end of the trait scale. And so you may not be able to differentiate between those two people. And that can happen at each end of any trait scale that you can imagine: depression, anxiety, and physical health and mental health, every domain. The last concept that I want to discuss so that we can really understand problems and their strengths and limitations is the concept of a minimum clinically important difference. So you see this a lot in literature. I'm sure you've heard of it, also known as a minimum clinically important improvement. This is the smallest change in measurement that signifies an important improvement, where the patient, if you ask them, they said, their PRO improved 10 points, but if you go talk to them, they say, oh yeah, I feel better. I improved since pre-op or since before the injury. So why do we need a minimum clinically important difference? If there's a difference, there's a difference. Why do we need to separately understand the difference that means clinical improvement? Well, the reason that we need it is because statistics alone won't tell us what a meaningful difference is, right? Because let's say as the sample size increases, the p-value decreases even with the same effect size. So let's imagine here on the right, two hypothetical treatment groups, one with PROMIS scores of 40, one with PROMIS scores of 44. And so if your number per group is 10, you're not going to be able to resolve a significant difference there. But as you increase the number of people per group to 40 and then 100, without changing the effect size, one group is 40, one group is 44, the p-value will become highly significant. And so you can easily get a significant p-value and a continuous outcome with enough sample size. And the question is, does it actually matter? Why do we need minimum clinically important differences? To ground this a little bit, because it's very easy to see a significant difference when it doesn't actually matter. And a concrete example of when this has happened is in evaluating viscosupplementation for knee osteoarthritis. So as you probably know, this is a treatment that used to be more common, a non-operative treatment for knee osteoarthritis that has now fallen a little bit out of favor in the most recent AOS clinical practice guidelines. The AOS recommends against viscosupplementation. And so how did that happen? Well, this is a great systematic review published in BMJ 2022 that actually lays out all the studies that have been done on viscosupplementation. And you can see we've had a number of very well-powered studies with a lot of patients who received visco and received placebo. And a lot of the effect estimates are to the left here. They favor viscosupplementation on this forest plot. And so at first it looks like, wow, this works really well. But if you overlay in the light indigo and then the darker indigo, a more conservative and then a more liberal threshold for minimum clinically important difference, you can see that despite many of the studies showing a statistically significant benefit, because again, they had a ton of patients, they were very well powered for viscosupplementation, none of the well-powered studies exceed even the lower threshold for a minimum clinically important difference. And so this is some of the evidence that has led to the AOS and others to realize that maybe this is not actually helpful. How do we calculate minimum clinically important differences? There's two main methods. One is a distribution-based method where we put all the patients on a spectrum, we calculate the mean and its standard deviation, and we just take half of the standard deviation. There's not a ton of theoretical basis for why this should work. It's sort of like a p-value of 0.05. It's become a convention and it's used, but it's not necessarily anchored to something real. And so a slightly more legitimate way to calculate an MCID is to use an anchor-based MCID. So what's that? So that's where you take a bunch of patients. So this is an imaginary group of 24 patients. And you give them the PRO. You also give them a question, hey, do you feel like you're better or not? And you lay out all the scores that they got on the PRO and all the answers they gave to, do you feel like you're better or not? And you try and find a threshold where above a certain score threshold, most people say that they're improved. And so you can do ROC curve analysis, which is just formal, graphing the sensitivity against the specificity. And you can try out a bunch of different potential cutoffs, and you choose the one that maximizes the combined sensitivity and specificity. Downside is that, like any cutoff value, you're going to have false positives and false negatives. Wherever you put that threshold, you're going to have people below it who actually say they are improved and people above it who say they're not improved. So almost wherever you put it, it won't be perfect, but that's how MCIDs get produced. And so you can see there's at least two different methods and a lot of potential noise and variation in how you might calculate a minimum clinically important difference. And so, there's a little bit going on there than just the number that gets put forward as a concrete objective threshold. And this was a nice study published in Core 2022 with 10,000 patients treated at Harvard with, procedures across the orthopedic surgery subspecialties, total hip, total knee, posterior lumbar fusion, total shoulder, et cetera. And these are the distribution-based or 1/2 standard deviation thresholds for MCID, as well as the anchor-based thresholds for MCID that they calculated for both these disease-specific patient-reported outcome measures as well as PROMIS. And all I really want us to sort of pay attention to here is that the MCID can vary a lot depending on how you calculate it and which population you assess in. It can vary 2 times or 3 times. So it's certainly not an objective set in stone number. So that's PROMS 101 and some of the basics of PROMS. And, you know, we've come a long way. PROMIS is like V12 of PROMS, and we're getting pretty good. You know, what are some of the problems? What are the limitations of PROMS? So there's a few. The maybe most straightforward and intuitive issue is that PROMS incorporate layers of recall and interpretation rolled into a single metric. And so what we want to know is a person's actual, let's say we're interested in their physical function. What we're interested in knowing is their actual ability to walk, run, work, you know, do things in their daily life that require a well-functioning musculoskeletal system. What we get when we give them a patient-reported outcome measure is their actual ability to walk, run, or work, as mediated by their recall of that ability when they're there in the office with you filling out a survey, as mediated by the comparison of their recalled ability to what their expectations are of how that should be, as mediated by their engagement with the survey. So are they tired, having a bad day, not able to focus, didn't have enough coffee, and are they, actually reading the questions carefully, or are they just kind of going CCC? And then after all that, you get a survey, you get a score, and that's their patient-reported outcome measure. And so by definition, patient-reported outcomes are measuring all of these things at the same time. In addition, PROMs are noisy and they're insensitive to objective differences. And so because all of these layers are rolled into the PROM, there's a lot of noise in the numbers, and they can jump around a lot, and there's variability even within a person across multiple measures. And so an article that comes up a lot on the OID and on boards talks about the difference in oxygen consumption in patients who have amputations between patients who have an AK and a BK. And it turns out that patients with a BK are able to get around with a similar level of oxygen consumption as patients without an amputation. But patients with an AK above knee need much more oxygen. It's much more draining for them to get around, 30 to 60% higher, in other studies, perhaps double. Despite that, when McKenzie et al. Looked at 161 patients in the LEAP study who had different levels of amputation, AK or BKA, the BKA patients did walk faster, but their patient-reported outcome measures were the same, statistically indistinguishable. That doesn't mean that the patient-reported outcome measures were wrong. Maybe the patients didn't care that they could walk faster, but it's certainly a difference between objective data and the survey data, the patient-reported outcome data. Another example of this, total hip and total knee patients, when they're asked to estimate how far they walked last week, their estimations are off by 50% or more from what a Fitbit measures when we give them Fitbits. And that makes sense. I mean, if you asked me how far I walked last week, I'd have no idea. I'm sure it'd be off by more than 50%. But it's certainly not a measure of, objective information about how much people are moving, how far they're walking. In a group of cancer survivors who were given PROMIS scores, they did the 30-second sit to stand test. It did correlate with PROMIS physical function, but it was a pretty loose correlation, as you can see here. And so seems like PROMs are measuring something a little bit different than objective functional outcomes. That doesn't mean they're wrong, but it does mean that that there's some noise and some variability. This was a study that I did that looked at about 100,000 PROMIS physical function surveys at the University of Utah. And we looked at the actual responses to the questions that patients had in the surveys, because there's some PROMIS questions because of computerized adaptive testing that a lot of patients answer. And so we looked at how they respond to these questions. And on one hand, look at the 2 hours of physical labor in the top row. On one hand, you see the expected shift in distribution of answers as you go up the score hierarchy. At the same time, if you look down a column, let's say look at patients who have a score around 40, these are all patients who scored essentially identically. There still is a distribution of how they respond to any given ability. And so you can see just within the answer choices that there is certainly a correlation, but a loose correlation between PROMIS physical function scores and patients' actual physical abilities. The last problem with PROMs is that it's very tough to detect poor function in a subset of your treatment groups. And so what does that mean? So this is a project that Nathan O'Hara at Shock Trauma and I are working on, which is pretty simple. It's a simulation-based study. And so we put together a simulated study with 400 patients. And we're imagining two treatment groups, group 1 and group 2, that have very different rates of non-union. So let's say nail versus plate, or one brand of nail versus the other brand of nail. We almost never see differences this large, right? But let's imagine that group 1 has a 10% rate of non-union and group 2 has a 20% rate of non-union, the red dots in the diagram here. And let's imagine that non-union patients have a PROMIS score of 40 and patients without non-unions have a PROMIS score of 50. And so that's 1 to 2 times the minimum clinically important difference. It's a pretty substantial difference. In this sample size of 400, what's our power to actually detect this difference in non-union rates, 10 versus 20%? We have pretty good power, 81%, so that's enough patients. What's our power to detect this difference in PROM scores between the two subsets? We have less than 5% power, so we have almost no chance that we will detect a true difference in the functional outcomes of patients with non-unions and without non-unions. And the reason for that is that the non-union patients still make up a minority of both groups. And so they're sort of the red dots on this simulated diagram here. And yes, their PROMIS scores are usually lower, but there's variability and they're a minority of patients. And so the actual mean PROMIS score in the treatment A and treatment B differs by only 1 point, even though we know there's a true difference between the non-unions and the patients without non-union. So what are some clinical examples of what we could call PROM failures or PROMs not matching up with our other information? So let's look at ankle arthrodesis versus arthroplasty. So this is a highly cited JBJS 2013 paper, ankle arthroplasty and ankle arthrodesis, gait analysis compared with normal control. So they looked at 17 arthroplasty, 17 arthrodesis. They did 3D gait analysis with these markers. They did patient-reported outcomes. Arthroplasty gave patients 32% better sagittal range of motion in their ankle. And yet the SF-36 scores and the ankle osteoarthritis scores showed no difference. That, again, doesn't mean that they're wrong. Perhaps that is amount of, that increase in sagittal range of motion doesn't matter to patients. But that disconnect is certainly something that should pull our attention. What about hemi-arthroplasty versus screw fixation for non-displaced femoral neck fractures? So another highly cited study out of Norway, JBJS 2019, was a randomized trial of about 100 non-displaced femoral necks treated with screws and about 100 treated with hemi-arthroplasty. Screw fixation had a much higher reoperation rate, 20 versus 5%. And at 12 and 24 months, screw fixation, hemi patients had 32% higher timed up and go tests. So a pretty big difference. Harris hip scores, though, were no difference. Again, not necessarily wrong. Maybe 32% different timed up and go doesn't actually matter, but another disconnect. What about nail versus plate for humeral shaft fracture? JBJS 2023, I like this paper a lot. One of the biggest studies comparing plate versus nail for humeral shaft fracture. 76 plate and 169 nail. Plate patients did better in terms of early range of motion and pain. They had lower reoperation rates. However, PROMs, again, were equivalent except for one of them, the constant Murley score. And so these are the actual graphs of the outcomes. We have range of motion up top. They saw close to 30-degree differences in range of motion all the way out to 6 months. So what we would think as clinicians would be pretty substantial, and yet DASH scores, EQ5D scores, SF-36 scores, statistically indistinguishable. Constant Murley scores were different just in the early time points. Again, maybe that amount didn't matter. Maybe the PROMs are telling the truth, but it does make you wonder and pay attention if we're measuring what we think we're measuring. And lastly, I want to go back to the health study for displaced femoral necks, hemi versus total. And so again, the health study showed no significant difference in functional outcomes except for the WOMAC total score, which was different, favoring total hip, but only by 6.4 points. The MCID, we think, is about 10, and so this didn't reach the MCID, so the conclusion was it's not a clinically important difference. But hopefully after everything that we've talked about the variability in calculating MCIDs, the challenge of detecting poor function in a subset, like let's say, for example, patients in their 50s who were part of this study were doing way better after total than they would do after hemi, but the patients in the other age categories had no difference. Would we be able to detect that? Almost definitely no, even though the study is well powered for the primary outcome of reoperation. And so it doesn't mean that there is a difference between total hip and hemi. And it doesn't mean that this study did anything wrong. I mean, they used the GOLD study outcome metrics for functional outcomes, and they chose a number of different metrics. But it does call into question, are PROMs giving us what we need? Are they, are they giving us the complete picture of patients' functional outcomes? And so if we're calling into question whether PROMs alone are able to give us the complete picture of patients' functional outcomes, and we want to add something or we want to look for something new, maybe we should go back to the drawing board a little bit and we should do a little bit of theoretical work and say, well, what really matters to patients? So some of this work has started to be done. And so Dr. Working and Dr. McKibben were on this paper published in JOT last year, which was a discrete choice experiment of patients with LC1 pelvis fractures. And so in this study, they presented paired hypothetical scenarios to about 500 patients with LC1 pelvic fractures. And these were scenarios like, you had surgery, it took you 14 days to get out of the hospital, this is your mortality risk, this is your mobility. Or you didn't have surgery, you got out in 7 days, and this was your mortality risk. And so they had to choose A or B, A or B, A or B, and do that over and over again. And the process of doing that, they were able to tease out people's revealed preferences for different outcomes. And so rather than this theoretical tiering of outcomes that Michael Porter gave us, we can get something that's based on data, at least for this condition, this injury. And it turns out that relative to their discharge location, their post-discharge pain, their secondary surgery risk, or even small differences in their mortality risk, that the thing that these patients cared about the absolute most was returning to independent mobility, returning to their baseline in terms of being able to get around and move throughout their life. So that independent ambulation is their top priority. And so the problem is we haven't really had a way to look at mobility and ambulation in patients' everyday lives directly, because they come into the office and we can interact with them there, but we don't necessarily see patients in their everyday life. And so we haven't had a way to look at patients' top priority outcome in their everyday lives. But that's now changing a little bit. So some of the work that I started in fellowship at Shock and I'm continuing here at OHSU is trying to sort of respond to this call. And that is using smartphone mobility data to try and track how patients are moving in their everyday lives. And so we have an opportunity that's really just in the last 5 to 10 years that, first of all, almost all adults in the US have smartphones. Which was surprising to me. I thought there was, maybe 60 or 70%, but 92%, and that's actually an old number now, of adults in the US have a smartphone. 61% are actually iPhones, because Apple just has remarkable market dominance. And Apple, about 5 years ago, rolled out in their Apple Health app a system where they're actually tracking step count and gait metrics on everybody who has an iPhone, whether or not you enable it. And so basically your phone knows how far you're walking, how you're moving in your everyday life, even before we met them. And so we wanted to see if this data, which already exists on half our patients out there in the world, is being collected passively, can help us understand the mobility of patients with fractures. And so we did a retrospective cohort study at Shock. We enrolled 107 patients with lower extremity fractures, pelvis down to foot and ankle. They were all adults. They were 6 months out from injury, and they'd had iPhones for at least a year, so they had pre and post data. We got patient and injury data from the medical record, PROMIS score. We gave them PROMIS scores in clinic, and then we asked them to export their Apple Health data. And specifically, what we wanted from their Apple Health data is we looked first, our primary outcome was step counts, and then secondarily, we looked at these other gait parameters that the Apple Health software calculates. And that includes walking asymmetry percentage. So kind of how much are you limping? Normal is about 10. A double support percentage, so how much of the gait cycle your foot is, both feet are on the ground, and so normal is about 20 to 40%. How fast you're walking, which for most people is between 1 and 1.5 meters per second. And what your step length is, and normal is about 0.5 to 0.75 meters. And so we had 5 questions that we initially wanted to ask of the Apple Health data. So our most important question was, we have this hypothetical curve of physical function that we imagine, but we can't measure it yet, which is patients are at some kind of baseline. They have an injury, their physical function falls off, they go through a 6 or 9 or 12-month recovery, and then they arrive at a new baseline. And so this change in physical health that we see pretty clearly clinically with our patients, is Apple Health picking up on this? If not, then it's probably not useful for us, right? So is it responsive to injury? Are these metrics responsive to recovery? Do they capture the improvement with recovery? We also want to know, do they correlate with PROMs? They might not, right? Because PROMs don't tend to correlate with a lot of objective measures, but we want to find out. Do they predict the speed at which people will recover based on baseline factors, age and demographics and injury? Do they differentiate between patients who have reasons to recover differently, even if they're otherwise the same patient, like they're having a complication such as a non-union? So this was our cohort, 107 patients, average age 45, 42% female, and the top fractures were plateau, distal femur, and femoral shaft. 39% open fractures, 25% of them had non-union surgery. And so again, this was, the theoretical physical function curve, baseline to injury to recovery to a new baseline. And this is what the step count data looked like. And so as you can see, we have a metric that actually is capturing, before we even met the patient, how they're walking, how many steps they're taking in their daily life. This is all 107 patients, and their baseline is fairly stable. They have a sharp drop off with injury, a slow recovery over about 200 days, a little over 6 months, and then relatively stabilizing into a new baseline that's lower than the previous baseline. And mixed effects models accounting for repeated measures showed highly significant differences from pre to post injury and immediately post injury to 6 months out recovered. The other gait metrics also captured injury pretty clearly, but improved and captured the recovery less clearly. So Apple Health gait metrics do track injury in the case of step count recovery. So the next question was, do they correlate with PROMs? Step count does correlate with PROMIS physical function. It's not a super strong correlation, 0.42, which is highly significant. And not super surprisingly, the other gait metrics don't correlate well with PROMIS physical function, and PROMIS pain also doesn't correlate with the gait metrics. So Apple Health gait metrics in the case of step count and physical function do correlate moderately, otherwise they don't correlate well. So our next question was, can we predict which patients will recover faster? Can we predict how fast patients will recover? And it turns out, even with our pilot sample of 107 patients, we can tell with an average accuracy of about 1,000 steps how many steps somebody will be taking at any point on their recovery curve. And so we put together these models, and this is an example observed versus predicted for step counts. And over the first 24 weeks post-injury, many patients are not getting back to their pre-injury baseline, but we are able to predict very, very tightly where they'll be in their recovery. And we can vary that depending on baseline factors. And so we can have a different prediction for patients who are 25 versus 75, or have a pilon versus a proximal femur, or have different baseline step counts. So they do predict recovery. And our last question was, do Apple Health metrics differentiate between patients with complications? And so we had a group that had a pretty high rate of non-unions, probably because we had such a high follow-up threshold. And so we had a 25% rate of non-unions. We were able to look at the non-union patients versus the patients who healed well. And the non-union patients are recovering their step counts 55% more slowly. So this made us ask, well, I wonder if you look at people's early in recovery step counts, if you could actually predict who will have a non-union at a time point, let's say 3 months, that generally is quite a bit earlier than we would diagnose it clinically on x-rays and clinical parameters. And so as pilot work, we looked at that as well. And yes, absolutely. If you make a model of all the patient's baseline factors and you say, how well can we predict non-union? The answer is somewhat well. The area under the curve is about 0.7. But if we add in 3-month step count, the area under the curve goes up above 0.8. So it improves the model pretty substantially at predicting which patients will ultimately go on to a non-union. And so this is a graph of 3-month daily steps as a percent of baseline and a predicted risk of non-union for patients with different fracture types. And so potentially we could get to a point, and we now have a grant from the AO to look specifically at tibial shaft fractures, where we could get enough certainty at 3 months with step counts, maybe with some biomarkers and with baseline data, that we can know at 3 months this tibia fracture is not healing, which we usually don't know, and we have to wait until 6 months or 9 months before intervening. And so yes, Apple Health Gait metrics predict non-union. So there's a number of limitations of the Apple Health data. For starters, we had about 20% of people in our pilot study that were missing data. Maybe they didn't carry their phone in a way that it could be collected. Maybe their phone software wasn't updated. Maybe they had declined or opted out of collection of this data. In our early sample, we probably oversampled adverse events. If you just go to people that are following up 6 months or more, a lot of people don't follow up 6 months or more, and so you're oversampling people who are having problems, and that's why they're coming back. Also, if we just look at Apple Health data, on one hand, it's quite easy. The Apple platform is very standardized versus the Android platform, which has all the same technology, is not standardized about whether the data is passively automatically collected or not. And so if we just look at Apple Health, which we did in the pilot study, we're relying on Apple's proprietary algorithms, which may not scale well, may not be ideal if we're trying to scale this. And 40% of patients, 40%, even if 60% of our patients have iPhones, which is pretty crazy, 40% don't. And that means that we can't follow how they're doing with just these methods. And so if you want to read more about this, the research group that I've been working with at Shock has 2 papers coming out in JBJS in the next several weeks. But more importantly, if you want to use Apple Health data in your own research, I'd love to help you. And this is just a walkthrough of how you can get started on that. And so for starters, you can always see a patient in clinic and just have them show their Apple Health app and how many steps they've been doing. And potentially in a clinical context, that could actually be somewhat illuminating. But in a research context, you're certainly going to want to export the data. And so the way there's a number of ways to do that, but the simplest way, the way that we did it, is that you have them go to their Apple Health app, tap their profile on the top right in this central screenshot, and then scroll down and tap Export All Health Data, and that will pull up a little screen like this. And then that will produce an XML file, which is a mostly unintelligible, machine-readable file. But you can convert that with an app or a script to a CSV spreadsheet file, and I can show you how to do that. And that makes a spreadsheet that's pretty straightforward and easy to understand. That in this case, these are just batches of steps, so it won't record the whole day steps. It'll record little batches of steps, and then if you want to have your outcome be daily step count, then you have to smash all those together in your stats software. And so then you bring that into R or Python, and then you can analyze it. And an easier way to do this, the group that I'm working with is also working on an app. We're working with an app development company that's called MindTrust. And these are some of the mock-ups from Figma. And so the way that the app will work, make it easier to follow and do research, and also feed patients back information on their Apple Health data. And so there will be a registration screen where patients or the research assistant will type in an anonymized ID. So all the data will go to the server completely anonymously. And then patients will sync their data prospectively going forward, so we can get a more complete sample and not a biased retrospective sample. And as the data is syncing from their phone to the cloud and accessible to you for your research, patients will also get some feedback on how their different metrics are looking since their injury. So in conclusion, there's both imperative in terms of value-based care and just a moral imperative calling to do a better job in orthopedic surgery to evaluate our functional results. PROMs are important. Certainly, they need to be more widely used, more widely collected, and ideally, we should get to a point where PROMs are one of the outcomes in every large-scale clinical study. But they have fundamental limitations, and they're not the endpoint in and of themselves in collecting functional outcomes. One potential augment that may be really helpful and may actually get at what patients really care about the most is continuous activity data from smartphones or potentially from other sources too. Most patients have this already. Half our patients are walking around and this data is already in their phone. And so should we look at it? Should we use it to understand how to take care of them better? And it's easy to use. In the future, what we'd like to do with the Apple Health data and continuous activity and passively collected activity data in general is maybe understand more about the natural history of conditions, compare treatments better. Oh, well, 2 treatments have the same problems, but patients return to their baseline mobility, 75% faster after treatment B. That makes me personally want to use treatment B. Can we diagnose complications at an earlier post-op time point, like non-union at 3 months? Can we better target therapy and other interventions like reoperation that we previously couldn't target well? Thank you. Yeah.
The first one that I wanted to ask, could you speak a little bit about the challenges convincing patients to release any of that data? And if so, do you have good strategies for study? And then my second question is about, I guess, validation of this metric. Do we know how much people are carrying their phones in the early recovery period? Or I noticed on the mock-up of the app that you have stride length as a parameter. Is that something that has been studied in the past?
Yeah, good question. So the buy-in question, we were pretty worried about that, and we thought that was going to be a big problem. And we thought, especially in a population that has a lot of skepticism toward healthcare, that people wouldn't want to give their Apple Health data. But it turned out that like 90% of patients that we approached were willing to share that information. And I think it all comes down to how you sort of frame it. And I think as the physician or as part of the care team, you have the opportunity to, let the patient, you already have a lot of information on the patient's health, and you can communicate with them that, if it's optional, of course, and it's research, but if they are willing to share this mobility data, that not only will we keep it secure and private, but it may help us, take better care of them and combine with some of the other information that we have to have a better sense of how they're doing. And so people responded better than we expected to that. And most people were willing to share it. But I certainly think that as you scale it, you have to, remain sensitive about privacy and security concerns. And partly why, as we're designing the app, we're, making it completely anonymous in terms of how the data looks when it leaves their phone. And remind me your second question again.
Just validation of this.
Oh yeah. So that's a good question. So all of the metrics have been individually validated by Apple, and they've published research on that, which helps. But you'd also like independent validation. Many of the metrics have also been independently validated in various research studies, and for the most part, the primary gait parameters are very accurate. The exception is double support time, which actually is not very accurate, and potentially, we may need to stop using it if they don't improve the algorithm on that. But yes, all the metrics have to some extent been validated. Certainly more validation work is needed though. Yeah.
I was just going to ask, was there any other ways that you could correlate or predict the post-injury step count after recovery as well, outside of just the baseline step count? So stratifying anything within the PROMIS survey, whether it was baseline activity level or mental health or something like that. I guess, was there any other way of predicting their step count after their recovery besides their baseline step count before their injury?
Well, so we did incorporate, and it's a good idea that you bring up, we did incorporate demographics and injury characteristics. So it was age, what fracture they had, was it bilateral, was it open, a few more things, plus their baseline step count. We did not look at their promise scores as a predictor of step count. I think it's a great idea. I don't know if it would be positive or not, given this, loose correlation between those things. But yeah, I agree with you that the more data that you bring to that prediction, potentially the more accurate you can be. Yeah.
This was a great presentation. Thank you for this. I'm curious if you guys, and I guess this would be more of like a post hoc analysis, but I've looked at people who are in like the lowest tertile or something of the step counts to see by zip code, like what areas they're coming from, because I feel like a big predictor of that kind of activity relates to a lot more of the social
Totally.
issues and neighborhood safety.
Yeah, I mean, I agree with you. I think there's tremendous questions about social determinants of health that you could get a much better look at with activity data, because that's what we want to know about, right? Like, what are patients' lives actually like? And the only way we're currently assessing that is with surveys in the office. We haven't looked at that in our pilot data yet. In part, it's such a small cohort. But maybe we should. I mean, I think it's a great idea, and I think it's a great data source for it. Yeah.
I have a little bit of a technical question. Did
Yeah.
you notice any variations between, I don't even know if you recorded it, different eras of the Apple iPhone, like iPhone 6 versus 10 versus 15, and the OS also, because it is proprietary data from a programming perspective?
Yeah, so we didn't, and I think that it would be worth looking at that. It would be, I think in order to really get at that, you would need to have do a study, which Michelle is actually working on right now at Indiana, where you compare proms to another gait measure, or some kind of gold standard, like a gait carpet or a 3D gait analysis or a marker ball study, and look at the agreement between the proms and the objective gait metric and see if that varies based on tons of factors like phone carry habits. That's one question we have. And yeah, I think iOS software and iPhone version, we could look at sort of, deviations between predicted and expected based on other variables within different phone version subsets, but I think it would be hard to tease out what's coming from the phone and what's coming from others. But I agree that it's another source of error for sure. Thank you, guys.
So I have an announcement to make, and it is sort of a semi-official announcement.